This session is entitled California, the Impact of the State Budget on Healthcare. And I'm sure we all have our theories. And that's why it's going to be good that we're going to have about a full hour to have questions amongst the panelists and from you, and maybe amongst each other, about what we expect is going to happen, what are the big issues we may not have thought about, etc. Instead of going over the obvious, that that the state is still in bad shape, that we're going to be cut, that healthcare costs are being regulated, that insurers are having their hands slapped, etc., I'm going to defer to the panelists to talk about all of the variety of issues they know so well about. What's enormously wonderful about this panel is that we're talking about people who have had the long view of California, who've worked in all sectors, and in most cases have been in and out of nonprofit, the private side, and government. So without further ado, I'm going to introduce our first speaker, who is Sandra Shewry, and the Director of State Health Policy at the California Healthcare Foundation, or to me, Mark's Place. She supports the work of policymakers and state agencies and departments through research analysis, technical assistance, and other things. She is somebody who really has been in and out of government, but one of the things I found very notable was that back in 2010, when healthcare reform was really heating up, she was on the planning team to help think about what we're really going to face now, how the exchange was going to happen, and of course we all look forward to hearing about that. And of course she was director, as you all know, of the California Department of Healthcare Services from 2004 to 2008. She has her bachelor's from Santa Cruz and her master's degree in public health and social welfare from UC Berkeley. Sandra, the podium's yours.
Good afternoon. We're going to switch directions a bit with this panel, and can we ever avoid talking a little bit about politics? No, but we're more going to focus on what's going on here in California. My job is to tee up the general themes, and so I've organized my remarks around the top issues that I would recommend you watch and get excited about as California goes about the task of implementing the Affordable Care Act. So the ACA provides this great national framework for reform, but the exciting thing for those of us who have made our careers in state government, and the other panelists who I've driven from the stage, is that the success of federal reform rests almost entirely on the states doing it right and getting on with it. And so it's really an exciting time in state government. The other side of the coin is, of course, we're in continued fiscal distress and considerable political transition. And we spent most of the morning hearing about that in the large national context, same kind of dynamics playing out here in California. Now, I'm going to break with what is the tradition today, which is pulling something from pop culture to sort of ground my remarks. And I'm going to be very traditional and ground myself in a quote. This is a quote about, we're continually faced with a series of great opportunities that are brilliantly disguised as insoluble problems. This is really, I would say, it's a very inspiring way to think about the world, to think about the challenges we face. John Gardner, for those of you who don't recognize the name, he was Lyndon Johnson's Secretary of HEW at the time that Medicare was launching. He was a Republican. He started Common Cause and was also a founder of the Corporation for Public Broadcasting. So I take great sort of inspiration and get a lot of energy from knowing that people who have gone in public service before me and before the colleagues that remain in public service were really took on these things that appeared to be insoluble and really made a go of them. So the ACA I used to have a list of about 12 great opportunities it created, and every time I speak, I try to boil them down. Because really, how many things can you rivet your mind around now that we're into the implementation stage? So these, I think, are the top 6 opportunities the ACA gives us here in California, and I'm going to go through each of them, so I won't read them to you now. I'm going to talk about all 6. The first is this idea of a 21st century enrollment experience. This is an idea we in California have had for the past decade, the idea of why shouldn't it be like applying to buy a phone or getting your credit checked? Why shouldn't it be easy to apply for a public assistance program? And indeed, the ACA, these are the things the Affordable Care Act requires, that we use a single streamlined application for all health programs, that we establish a website that lets people apply and enroll and renew their enrollment, and that we establish outreach mechanisms for enrollment of vulnerable populations. I mention this to this crowd because in Sacramento, this is everything to the people who watch public programs. This is the issue that they wrap their minds around. And I'm not sure that in the broader health community, people realize the importance of this. The ACA, the vision is near universal coverage. If people can't get in the door to get that coverage, if it's not easy for them to make the choice, to fill out the papers, to get enrolled, the thing breaks apart. So this is a huge opportunity we have in California to really provide leadership on this. Second opportunity is, of course, the exchange. And this is probably what most people are familiar with. It creates this new marketplace for insurance. California tried this in the 1990s with something called the Health Insurance Plan of California, the HIPIC. You may remember that was a small employer purchasing co-op. We've had private entities in our state that have tried this. Now we see a national policy, an exchange with the thing that was always missing, federal tax credits to support the purchase of coverage. The federal government's going to pay to establish the exchanges through the end of 2014, then they're going to stand on their own with the people buying through the exchange having access to the tax credits. This exchange, again, the ACA gives the framework, but all the fun and the action is at the state. And you're going to hear later from one of the exchange board members, but the exchange has amazing authority and discretion in terms of how to create and mold this new marketplace. They get to figure out how to approach purchasing, how they're going to look at plans, what kind of contractual terms they're going to hold them to. They're going to decide what kind of linkage their business partners need to have with other programs or broader goals. They're going to be able to look at the relationship between plans and their provider networks. And they're going to be able to look at things like, should they standardize benefits? Or should they put every product on the shelf? And then they get to make a lot of, I'm going to call this fun, but I don't really mean that it's fun. It will be really hard. A lot of decisions around distribution and marketing. How should they get the word out about this new marketplace? And how should people who are doing the distribution be reimbursed for the contributions they make to building the enrollment? The third exciting opportunity is delivery system reform. And here, really what you see in the ACA is the undercurrent running throughout it is the move away from volume-based reimbursement. The ACA doesn't really say it in this kind of bold language, to outcome-based reimbursement. And that's something that everyone, it's a different way of talking about aligning incentives. And great opportunity for those of us involved in the public sector to think about how we purchase care, but also really a national trend that private purchasers can also piggyback on. Another opportunity is, for the first time, the federal government's willing to look at how we can do a better job and rethink the delivery system and care models for dual eligibles. Most people know there are over 7 million people on Medi-Cal in our state. Over 1.1 million of them are dually eligible for Medicaid, Medi-Cal, and Medicare. And there are some of the highest cost enrollees in the Medi-Cal program. So really exciting to see that the federal government wants to partner with the state on trying to improve the experience for those people and perhaps the health outcomes. And then the last thing on delivery system reform is really this idea that the exchange, large employers, CalPERS, and our Medi-Cal program might throw in together and collaborate on things like purchasing standards, who they're going to do business with, on metrics for judging performance of the delivery system, and perhaps on financial incentives. All tools that are in use today in the delivery system, but that could be made more powerful if people throw in together and are buying now for 5 million Californians, perhaps instead of 1 million, which sounds like a lot till you think of how big our state is. Another opportunity, rethink the care delivery process. This is the stepchild issue, and I think a really exciting one. Another way to talk about this issue is just workforce. We're going to have over 4 million newly insured, newly covered people come 2014. That is great news. But it really requires us to start thinking, I think, a little more focused and in a little more active way about the type, the number, the distribution, and the cultural competence of that workforce. I like to think of the possible solutions, and I hope there are more, as falling into these 3 buckets. One is the training, the pipeline. Can we move people faster through the existing pipelines? Even if we could, unlikely we'd end up with enough of them by 2014 or 2015 or 2016. Licensure, another way of saying scope of practice. And there's really 2 ways to look at this issue. Are people today being encouraged to work at the top of their scope? There's a whole body of research being created that says we actually don't need to change the scope laws. What we need to do is work with medical groups, with clinics, to just be sure that the people who are working in those systems are at the top of their scope and doing as much as they can. The other issue on licensure is maybe we need some new categories. Maybe we need to expand the scope of licensure for some of the professions. And then the third is the increased use of technology. The ideas here are, what could we do using home monitoring? What could we do using asynchronous telehealth applications where you might have a scan or an image stored that a specialist could read at another time? What can we do with video conferencing? So really trying to embrace technology as a way of extending our workforce. And then this one probably is one of the best well-known opportunities in the ACA, leveling the playing field for health plans. This began right away with the passage of the ACA, and the federal standards are being phased in between 2010 and 2014. Many of these new federal standards either require, or it would be really in the state's interest to have state conforming law so that it's clear to plans in our state what the rules are. They have one body of law they can go to. And then there are contained under this level the playing field idea of the ACA, new and expanded functions for state and federal government. The management and tracking of the minimum loss ratios, the risk adjustment processes, and then rate review, which our state has some history on, but which you see really coming up in prominence from our regulators. And then the last one is the review and realignment of both governance and financing of state programs and regulatory structures. You know, we have a huge infrastructure in place today that has grown out of the fact that we have so many uninsured. So we have a lot of state programs that are intended to plug a gap. We have a breast cancer screening program. We have a HIV/AIDS drug assistance program. We have programs that really try to fill the gap. We have a high-risk pool. And so if the ACA moves forward and is successful in bringing people into coverage, do we need that same configuration of state programs, or is this really an opportunity to rethink what gaps remain and how much public money needs to go into them? Same thing with state departments and regulators. We see Governor Brown proposing to consolidate state government, moving the pieces of the Departments of Mental Health and Alcohol and Drug into the Department of Healthcare Services, and then state and county relationships. Right now, counties have responsibility for about 1 million medically indigent Californians. If the preponderance of those, if many of those people come into coverage, what should the financial and governance flows look like? So again, another opportunity to step back, This one is not anticipated in the ACA. The ACA is silent on all of this, but really here at the state level, we have an obligation and an opportunity to think through how we finance care for indigents. So just to talk about the overall California budget context, we went into this year and the governor's got his proposal down on the table, and everyone always reminds each other it's always just a place to start. It's looking at a $9.2 billion deficit, and he's proposing to close the deficit with an increase in revenues through taxes, through a ballot initiative, and then also $4.2 billion in cuts. I only put this slide up really to say that of note to me, and is that in Governor Brown's talking about his budget, he noted a lot of really important priorities: green technology, education. I was listening very carefully at the State of the State. I don't think I heard the word health mentioned. So I only say that to say that the big riveting issue for our chief executive of our state is the economy and trying to get our financial house in line. It is not the issues that many of us toil day in and day out on: healthcare and healthcare access and health improvement. And then just to sort of sober us up, those of us who have worked in government or are around government, where I was saying, oh yeah, you know, there's a lot less of us around. And I think the public, do you remember the slide this morning, sort of how the budget really is spent, and it had wedges for everything, and then how the public thinks about public funding? There was the little wedge and it was all waste. Well, it actually is true. There is less. It's true that we have been cut. So our resources that we as a people put to work in service, in public service, have come down. Our expenditures and our revenues are down from those high points. And so this has happened in the context of government funds shrinking, but not the responsibilities of government. So that slide I had about the realignment of trying to bring things into alignment with revenues, with new responsibilities, comes out of this. So as we're going into 2012, I would suggest to you these top three are the top three issues to be watching here in California on ACA implementation, and these bottom three are sleepers. The first one is that eligibility and enrollment issue. The state today for the Medi-Cal program has 3 systems for bringing people in and determining them eligible. They're all based on the same rule base, but 3 IT systems. There's a 4th system that the Healthy Families program uses. So here the ACA is saying, we want a streamlined system. We want it to make real-time eligibility determinations. We want it to be online. We want it to be super slick. So a really big decision point for our state, and then you also have the exchange in the mix at this point. So a really big decision point for our state, and one that I think is deserving of your energy and attention, no matter where you are in the health sector, is what are the policy decisions our state makes on how to open the door to millions of people who will be eligible for coverage. How simple can we make it? What kind of checks should there be today? It's a big deal in government to accept an electronic signature. So there's a lot of little policy buried. You know, will this new system incorporate it? I'm assuming yes, but this will be sort of a breakthrough in how we do public programs. So I advise you to stay on that issue. The next issue is exchange planning. That's probably the one where everybody's excited about it already. The board meets in public. A lot of people show up. They're meeting about twice a month at this point. They've started hiring their staff. You're going to hear from one of the board members, give you a lot of detail about it. But what I would advise you to keep your eye on in terms of exchange planning is how are they reckoning with trying to balance the affordability of the product that they're going to offer with people's expectations. You know, people who are going to be receiving coverage through the exchange and taxpayers who are going to be financing the subsidies probably have an idea of what the coverage is going to look like. One of the speakers this morning, I thought, put out a really interesting fact that nationwide we're seeing this huge increase in high deductible plans, and that is not the truth in California. That's not our reality. Our reality is much more comfort with a prepaid, low copay HMO model. And so how is the exchange going to balance our expectations, our view as Californians of what health coverage is, with the need to make that product affordable so that people with subsidies, because they're still going to need to put their own money in, can afford to come into coverage? And then the Medi-Cal expansion preparations. The Medi-Cal program is going to grow, and Len Finocchio is going to talk to you in a minute about what they're doing to get ready for that. It's going to grow by up to 2 million people. Really a big deal, 7 million enrolled today. Huge expansion, largely going to be childless adults who were not categorically eligible previously. So the preparations they're doing are things like trying to understand what is the health burden of the new eligibles. Are they going to have more alcohol and drug and mental health conditions than we've seen in the current Medi-Cal population, which is largely mothers with children, some families, and then people with disabilities. They're also, the Medi-Cal preparations is one of the big, bright, shining stars right now in our state. They've got 10 counties that are already using county money to bring the people who will be eligible for the federal program in 2014 in today. And I'm sure Len will talk about that, but that's one to really watch because they're learning how to enroll people and what the healthcare needs are of these people. So really, it's a good news story. And then my three sleeper issues, an undone chore in my mind is that the ACA has 3 different risk adjustment ideas, because once we've tried to level the playing field for health plans, we still need to do some kind of a correction if Plan A gets a maldistribution of risk. And so that is part of the law. In California, we have not designated any entity in state government to be in charge of that. I think many observers assume it will be the exchange just because the exchange is doing everything that's new. I don't know if that makes sense. I mean, we haven't had the public discussion about it. In my mind, it could just as easily be one of the regulators or the regulators in collaboration, or maybe an entirely new entity. Now, if we do nothing, there is a federal process underway, but generally California doesn't rely on federal processes when there's a chance to create it ourselves. So that's an issue that could pop up this year, could pop up in 2013, but who's going to do this? What would risk adjustment look like? There'll clearly be federal guidance on it, but also state thing. Workforce, again, and if any of you work for health plans, I would say my counsel to you would be start talking about this, because there is no state entity responsible that the director gets up every morning and says, okay, I have to have a workforce adequate to meet the needs of the people. There isn't anyone with that job in government. So I was trying to think, well, how does this get fixed? One of the ways our policymaking has fixed it is timely access regulations for our health plans. I think put the health plans in a real responsible adult in the room kind of role on workforce. Because if you as a health plan need to assure your regulator and assure the public that you can provide the kind of access that we want for people who have a health plan card, I think you just won the ticket as who's responsible for workforce. And so all those ideas about speeding up the pipeline, funding for the pipeline, what you can do about scope, what you can do with technology, I think really land. You could play, I think, a very positive role in spurring this issue along. And then the third one I haven't mentioned at all is this progress on the federal data hubs. In order for the ACA eligibility and tax system to work, the federal government has to build some data bases at their end and some technology solutions. The ACA really sees linkages to Homeland Security to be sure people are legally present in the US, because the INS is in that part of the federal government, sees a connection to the tax system through the tax subsidies to people, and then also to the Social Security system. And so really the reliance on the federal government, that's the piece that they really need to be doing the heavy lifting on an IT build before 2014. So the window of opportunity is open. I think it's the kind of time in careers of people who would like to see our nation move to near universal coverage that has never come around before. I liked this picture because to get to the window, it's going to take a little bit of work. We're going to have to climb up the ladder. But I'm very excited, and I hope I have contributed to your ability to think about how to track the ACA and what are the issues of prime importance to getting there as a state. Thank you.